Yeah. All right. Good morning, everyone, and welcome to our cardiology grand rounds. Today, we have the pleasure of hosting our very own Dr. Smallfield, who completed her internal medicine and cardiology training and then advanced heart failure training in 2010 at the University of Alabama at Birmingham. After 2 years on staff at UAB, she came here to VCU in 2012 to join our transplant cardiology program and has been working here ever since. She is one of our heart failure attendings and the fellowship director for the Advanced Heart Failure Fellowship. Her clinical interests include advanced heart failure, mechanical circulatory support, and pulmonary hypertension. And I can speak for the rest of the fellows that we always enjoy and love working with Dr. Smallfield, conducting rounds through our cardiac and cardiac surgery ICUs. And we're all looking forward to her presentation today on cardiogenic shock. As always, CME will be provided. So there's a slide here at the start. So please text the code in order to gain credit for the presentation. And without further ado, Dr. Smallfield, we'll turn it over to you.
Thank you, Jeff, and good morning to everyone. Today, I was going to speak with you guys about a multidisciplinary approach to managing shock in the ICU. I have to say, I really enjoy this first picture because I am not an expert in shock. When I was asked to do this talk, I was a little bit nervous because my impression of doing talks is that you talk about stuff that you know a lot about. And I didn't really know a lot about shock, but I have learned a lot and hopefully can talk about this with you guys today. So our objectives today, I wanted to define and classify cardiogenic shock and then review the morbidity of cardiogenic shock and how we can identify shock earlier, and then present some other team approaches, some multidisciplinary team approaches to cardiogenic shock at some other centers. And the reason that we're wanting to talk about this today, really the whole shock team here at VCU, is we're trying to revitalize our own shock team. And we're sort of in the early stages of going through protocols and how this might look here at VCU. So let's just get started. So the first objective, I found this picture and I really liked it. It was in an ER doctor reference, but I felt that it was a great representation of what is involved with shock. So shock normally has these four characteristics. We have hypotension, which is normally defined as a systolic less than 90 or a MAP less than 70 or greater than that on pressor or inotropic support. We have some measure of hyperperfusion. So either there's decreased urine output, creatinine or LFTs are elevated, lactate is elevated, maybe there's some altered mental status or the patient is kind of cool. We also then have some low cardiac index, normally defined as a cardiac index less than 2.2, and some measure of elevated filling pressures with hemodynamics, normally a wedge pressure greater than 15. And I say normally because there's many different sort of definitions of shock, which is part of the problem. That sort of every trial kind of defines it a little bit differently, but there's normally some measure of blood pressure, of perfusion to the end organs, and then what their hemodynamic criteria are with their cardiac index and their filling pressures. So a sort of older way of classifying cardiogenic shock was taken from actually Lynn Warren Stevenson in 2005 when she described heart failure. But there's some measure of volume status and some measure of perfusion. And when we're looking at our classical cardiogenic shock, I think as everyone knows, but this is the cold and wet patient where they have low cardiac index, they have high SVR and high wedge. We can have patients that are cold and dry, meaning that they're poorly perfused with a low cardiac index, and their SVR is high, but their wedge pressure is normal. And then up here in the upper part, the mixed cardiogenic shock, where a patient is warm but wet, and then shock that's not cardiogenic when a patient is warm and dry. And this is, from this point, the SCI organization wanted to make the stages of cardiogenic shock. And there was a lot of reasons for this. This was developed in 2019. One is that they were just using that old classification of shock of a patient that's cold and wet. But I think as everyone who's done a rotation in the CICU, there's a wide range of patients that are in cardiogenic shock. So I think for that, they were wanting to make some stages that could further kind of classify patients. This would also be more helpful in using this in clinical trials, which there's not very many clinical trials on shock. And they got, what I think is interesting, maybe not everybody would think is interesting, but they actually got this idea of the stages from the INTERMACS profiles. So the INTERMACS profiles is a ranking of patients' severity of illness going into VAD implantation. And the first author on the SCI classifications of shock paper in 2019 is David Barron, who's a very famous heart failure physician. And maybe this is where they got the ideas. But for the INTERMACS profiles, there's profile 1 through 7, and they kind of differentiate the severity of illness in the patients. And they have these key phrases that were easy for people to remember. So, profile 1, a patient in critical cardiogenic shock, they came up with the phrase of crash and burn. For profile 2, which is a patient that's not doing well on inotropic therapy, sliding on inotropes. Patient 3 that's stable, but on inotropes, they would just say stable on inotropes. And so it was like a term that was much easier to kind of remember and help to define that class of patient. So going back to the SCI classifications, they divided this into 5 stages of shock and had a little catchphrase for each one. So stage A is at risk, and these are patients that are coming in with an acute MI or acute heart failure, but so far do not have evidence of shock. So their blood pressure and perfusion remain pretty normal, but they're at risk of developing shock. And then stage B, which is the beginning. So this is someone who is hypotensive or tachycardic, but right now they still have good perfusion, but could have the risk of continuing on to what is called classic cardiogenic shock. And these are the patients that I think we're most used to seeing. A patient that's hypotensive, that's poorly perfused, that's already on inotropes or pressors or mechanical support, and relatively hypotensive. And then kind of moving into stage D, deteriorating or doom, which I think is kind of funny, but I have a weird sense of humor. But these patients that are deteriorating are the patients that are the classic cardiogenic shock patients in stage C, but getting worse. So they're already on inotropes and pressors and mechanical support, but continuing to do poorly and needing of more intervention. And then extremis, or I kind of call this the end, is when the patient is already on all of this support and is essentially coding. So they may be requiring CPR. They're having multiple interventions by, multiple different groups of physicians, and these patients are most likely not going to survive. And this is just another table from the paper in 2019 that kind of explained all of these patients again. We mostly just said this, but essentially, at risk, these are patients coming in with an MI or with heart failure, right now still normotensive and still well perfused, and kind of progressing all the way down from beginning classic cardiogenic shock, deteriorating, and extremis. And these patients in E are probably not going to survive. So I just wanted to review quickly some of the morbidity associated with cardiogenic shock and what are some possible solutions, like identifying these patients a little bit earlier. So I think, as we all know, these initial trials about shock, which are from the late 90s showed that the mortality of cardiogenic shock is quite high, 40 to 50%. One of the initial shock trials was in 1999, and what they were looking at in this trial is comparing, these were patients only with acute MI, and they were comparing early revascularization to standard of care. And so what they were looking at is in 152 patients, they revascularized them with PCI or CABG versus 150 patients that just had medical stabilization. There was a high use of mechanical support in both the groups. Balloon pump was used in 86%. They looked at a primary endpoint of a 30-day all-cause mortality, and then their secondary endpoint was survival at 6 months. And what they found is there wasn't much difference, or there wasn't a statistical difference in the 30-day mortality, but they did see a statistical significantly difference in the 6-month mortality. So 30-day mortality, 46% in the revascularization group and 56% mortality in the medical therapy group. When looking at 6 months in the revascularization group, the mortality rate was 50% and 63% in the medical therapy group, and that was significant. But what really gets me about this study is how high the mortality is. This is like 50% or greater mortality at 30 days just from coming in with cardiogenic shock. So I think, as we all know, the treatment for acute MI and the treatment for acute heart failure has really advanced over the last years. You know, we have PCI and high-risk intervention for acute MI. We have all sorts of temporary mechanical support and durable mechanical support for patients that continue to have refractory shock. So I think it would be assumed that probably mortality has improved, but that's not really the case. So contemporary trials are still showing that a 30-day mortality is still around 30 to 50%. And this was part of the reason that they wanted to develop those sky changes of shock, because these patients are quite heterogeneous. There's a big difference between a patient coming in with acute MI that's at risk for shock versus the patient that's on ECMO and inotropes and doing poorly. So they were looking at this in terms of making the sky stages and seeing if they could do further development in terms of studies with cardiogenic shock. And so there was a contemporary, there was a statement released from the AHA in 2017 on cardiogenic shock. And this was saying some of things that are very similar that we've been saying for the talk, that, you know, cardiogenic shock is multifactorial, it's hemodynamically diverse. There's a wide spectrum of patients that come in with cardiogenic shock. It can be associated with multi-organ failure and still has a high mortality. And they were saying that we needed a coordinated approach with a multidisciplinary care. And this should be done in designated centers that have expertise on cardiogenic shock and the means to take care of these patients. And they recommended clinical trials and registries to see if they could improve the quality of care for cardiogenic shock. And this was taken out of the paper, that these endeavors could form the basis for future scientific discovery, guideline development, and improvement in patient outcomes. So this wasn't too long ago. This was just 2017. And so what are some of the possible solutions? We know these patients that by the time they're even in classic cardiogenic shock stage C, that these patients are pretty sick. They're requiring pressors, inotropes, mechanical support. We know that they have a very high mortality. And what can we do about this? Because it doesn't seem that over time that their mortality is changing, even with our improved care. So one thing is that we could try to find these patients earlier in their time course. So really we would be looking for these two groups of patients, the stage A and stage B, the patients that are at risk for developing cardiogenic shock, and then the beginning of cardiogenic shock, where these patients are hypotensive but still have good evidence of perfusion. And so one thing I just wanted to touch on briefly is, this is something that we're already doing here at VCU through our Navigator program. And so the Heart Failure Navigator program is inpatient nurses that review the admissions, looking for patients with heart failure and other high-risk features that may make their mortality higher. And so this is just a flow chart that we've been using, and anybody who's been on the heart failure consult service is kind of familiar with this. But a patient with heart failure is admitted. It's reviewed by the nurse navigator. And if the patient has an EF of less than 35% and meets other high-risk criteria, the nurse navigator will notify the primary team, but also talks to the heart failure consult team. And we then review this case. And, many times it's a heart failure patient that's admitted for other reasons, but we do review the case, review the chart, and then we decide, is this a patient that we should see in consultation? Is this someone that just needs early follow-up in the heart failure clinic? Most of the time, it's going to be that we're going to at least, contact the team, see how the patient's doing, and see if the team feels like their management is okay, or do they feel like they need additional assistance. And I have to say that probably at least one time a week that I do consults, I end up seeing a patient that does need to be transferred to cardiology or even the ICU because they're in like frank cardiogenic shock on a medicine floor, and people just haven't maybe fully recognized what's going on with the patient. And so some of the high-risk features that we're looking for and that identify these patients are kind of similar to what we're looking for in patients with cardiogenic shock. But these patients can be tachycardic, they can be hypotensive, they have evidence of elevated creatinine, low sodium, high BNP or NT-proBNP. Their LFTs may be elevated. They may have an elevated lactate. They're a patient that has frequent heart failure admissions. And then other things that I think are important to kind of recognize, this might not be on the admission, but when you're looking at your sick heart failure patients in clinic, any patient that you're having to escalate diuretics for, or any patient that we're having to withdraw their medical therapy due to hypotension or worsening renal function, these are patients that are at high risk for worsening heart failure and possible admission for cardiogenic shock. And one thing I do like to tell, the fellows and stuff that are on consults, but also I hope that we're kind of educating our medicine colleagues, is that if you're not looking for cardiogenic shock, you may not find it. So if you're not checking a lactate or you're not checking LFTs, you may not see that this patient is slowly decompensating. And I think those are good measures to kind of follow on the inpatient side. Okay. And so what are some multidisciplinary team approaches to cardiogenic shock that have been successful with other centers? And this chart was made by Pen Yang, one of the third-year cardiology fellows, and he will be our heart failure fellow next year. But this is a summary of some of the multidisciplinary team approach studies looking at cardiogenic shock, and we'll kind of go through a few of these right now. But so one of the first studies was, this is out of Utah, and they were looking at a shock team approach for refractory cardiogenic shock, requiring temporary mechanical support and seeing if this was feasible. So this was really a feasibility study and looking at the efficacy of a shock team approach. Their time period that they were looking at patients was from 2015 to 2018. And what they did during this time period is prospectively looked at 123 patients that came in with refractory shock receiving a temporary balloon pump. And after they had those patients, they compared it to the the preceding 121 patients before this time period that came in with shock and temporary mechanical support, but was before the time that they had the shock team approach. And their primary endpoint was looking at a 30-day all-cause mortality. And what I liked about this paper is that they gave a little bit of information here at the top as to sort of how they did their shock team. So they, anywhere where a shock patient could be, so in the emergency room, in the cath lab, in one of the ICUs, or in the operating room, anybody could kind of page out the shock team to let them know that they had a potential patient. And their members of the shock team was a heart failure cardiologist, one of the heart failure CV surgeons, an interventional cardiologist, and then the ICU attending. And their branch point was, is this patient having a STEMI? Yes or no? If they are having a STEMI, clearly needs a left heart catheterization, a right heart catheterization, and to see if they need any temporary support. And very similar if they're not having a STEMI, but trying to put in the Swan catheter quite soon, deciding if they needed temporary support, and then deciding what other care they would need. This bottom graph down here is looking at their 30-day mortality, and they did find that the patients with the shock team approach had better survival than patients without the shock team approach, and it was statistically significant. I don't think I wrote the numbers down here, but I think the 30-day survival was 62% with the shock team approach and 47% before the shock team approach. Something similar, looking at a Canadian experience published in 2020. This was looking at 100 patients over 52 months. 64 of those patients was during the time course where they did have a shock team approach, and that was compared to 36 patients in a time period before that where they were just using standard of care. What they did find is that there was no significant difference in the length of stay of the hospitalization or survival to hospital discharge, but they did find that the overall survival was much improved in the shock team arm. So 67% versus 42%. And I can show you that here. So their initial, lines are pretty similar until about 90 days. And that's when they sort of split. And that's where overall survival is much greater using the shock team approach. And they also gave a nice sort of diagram protocol of what they do for their shock team. And they have the criteria here. So evidence of hypotension and evidence of hypoperfusion. They used a systolic pressure less than 90, a cardiac index less than 1.8, or if you had numbers that were higher than this, they had patients that were on doses of inotropes. And they say here that the moderate doses of inotropes was dobutamine greater than 5 mics and milrinone greater than 0.25 mics. And then you have evidence of hypoperfusion, some measure of urine output that's decreasing. You have elevated creatinine or elevated LFTs, and you have an elevated lactate. And how they did it is they essentially had a KICU review. So the KICU team would discuss this patient and decide if they're in shock. If they are a patient in shock, they would then discuss it with the heart failure team and then activate code shock. So their exclusion criteria that they were using is patients that were still undergoing resuscitation or CPR. And then if they had had a prolonged cardiac arrest greater than 30 minutes and not having much probability of a neuro recovery, or their life expectancy was already less than 6 months. Once the heart failure team would review the patient and make sure that there wasn't any contraindication to mechanical support, They would then have a shock team meeting, and that was including the 4 groups, so heart failure, CICU team, interventional cardiology, and the cardiac surgery, to decide what was the best option from there. And so this is sort of the ideal, that you have all 4 teams kind of talking together about what are the possible options, either temporary or durable, that we can then do for the patient. Okay, second to last one that I'm talking about, but this is the CCCTN network, or the Critical Care Cardiology network in North America. And they were looking at consecutive admissions to the CICU over an annual 2-month time period. So each program had 2 months that they would be looking at patients between 2017 and 2019. And 10 of the 24 centers did have a shock team, and those 10 centers had about 44% of the admissions. But so something very similar to what's already been talked about in these other programs is that you have a patient that you think might have cardiogenic shock. You activate the shock team, which is made up of your CICU cardiologist or intensivist, your heart failure team, your interventional cardiology team, and your cardiac surgery team. You then have a rapid evaluation with all members of the team together. You quickly get invasive hemodynamics if possible, and then decide on your approach to treating the patient. The patients that they had in their study were pretty matched in terms of whether they were treated with the shock team or without the shock team. So very similar in a lot of contemporary studies is the amount of patients being admitted with acute MI is decreasing, and the amount of patients being admitted with acute heart failure is increasing. So in this study, less than 30% of the patients were admitted with an acute MI. They did have elevated lactates. They had elevated filling pressures. They had low cardiac index and a low cardiac power, though still above some of the definitions. That's less than 0.6, but measure of contractility there. And so their results, they found that with the shock team, they had much more use of Swan catheters. Their overall use of mechanical support was less, but when they did use mechanical support in these shock team patients, they used advanced mechanical support, which was anything above a balloon pump. So they were using Impella 3.5s, tandem hearts, surgically implanted Impellas, and then ECMO. And they found that their mortality in the ICU was lower using the shock team approach. So last one, and this is I mentioned this one because this is the approach that we're sort of mimicking and what we're trying to do. This is the group from Fairfax Inova, and their shock team started in 2017. And what they were looking at here is their 30-day survival according to etiology, so whether it was an acute MI or acute heart failure, and then time period. So they mentioned that before their shock team started, their survival was about 42%. Their 30-day survival was about 42%. Their shock team sort of started in 2017. The blue line is acute MI and the red line is heart failure. But you can see that their survival started to improve from that 42% up till their more contemporary time period in 2018, where their 30-day survival was, really excellent in compared to other studies. So 82% in acute MI patients and 72% in acute heart failure patients. And then they have this nice algorithm that's, again, very similar to what we've been seeing, but, rapid assessment of the patient, looking at blood pressure and organ perfusion, and hemodynamics to decide if the patient is in shock. If they think that the patient is in shock, you activate the shock team through one number, and this pages all 4 participants of interventional cardiology, surgery, heart failure in the ICU. And then either they take the patient to the cath lab or to the ICU, depending on what they think. But essentially, they get a Swan catheter placed, get hemodynamic assessments, get echocardiograms, get all the information that they need for down here. So if the cardiac index is less than 1.8 without drips or less than 2.2 with drips, considered cardiogenic shock. If they have elevated filling pressures, if their cardiac power output is low, and if their PAPI is low, they then make a decision about whether or not they need temporary mechanical support. So one thing also that I thought was very interesting about their shock team algorithm is that sort of here at the end, they have a place where the team gets together again to discuss whether or not the patient can be weaned from support or if they need an escalation of support. And not in this algorithm, but in the paper, they talk about that then the team should be involved if we decide to wean for palliation, and discussing that with the patient and the family. So that went really fast. I apologize for that, but hopefully we talked about these 3 things today, that we defined and classified cardiogenic shock, reviewed some of the morbidity and ways that we can maybe intervene sooner by identifying shock earlier, and presented a multidisciplinary team approach to cardiogenic shock at other centers. And this is something that we're hoping to mimic here. So this is the VCU shock team right now. And if I forgot anybody, I'm very sorry. But we do have members from our CICU, from our CICU, from CV surgery, from heart failure, and one of the CICU pharmacists, Cassandra. Right now, we are missing a vital group, which is the interventional group, and we're hoping. I know some of the people that are interviewing are very interested in shock, and so hopefully we'll find a good match there. Just to go back to my first picture where that you need to be expert only, double black diamond. Hopefully at the end of this talk, we can have just a nice powder day and enjoy ourselves. And I'd be happy to take any questions.
Well, thank you, Dr. Smallfield. That was a great overview, and especially the intro to the shock team approach that we're going to be adopting here. So anybody, feel free to ask questions in the chat or send them through to me. I do have a few questions. I always have questions, though. So one of the things, so first off, I see a lot of similarities between, the sort of the push from SCI to lower mortality, actually as like the treatment for septic shock. I mean, I think that's what the medical ICU has been trying to do for years and years, designing studies to get past that, what seems to be like a barrier at 50% mortality. The shock team seems like a good approach. There's been some observational studies that you presented here and pre and post intervention. I guess one of the questions I had is, what do you think that the shock team, like, what are the ways that it's mediating perhaps an improvement in mortality? Is it from earlier recognition? Is it because we're sort of better together, using, several heads are better than one, and figuring out what the best approach is that somebody else may not immediately see? I'm not really sure entirely. I don't know what your thoughts are.
So I think it's 2 things. One is I think by, and actually at Inova, they told us that they have this algorithm like posted in those places where the patients could be. So posted like in the cath lab and posted in the ER. So I think one is more rapid or earlier assessment of the patients that are in shock and just more recognition of what it means for a patient to be in shock. like many times I get called from the emergency room and they said, well, the lactate was only 3. And I'm like, a lactate of 3 is not normal. Like that's important that we recognize that and can see that that's a patient that might be in trouble. So I think some of it is just earlier recognition and just identification of the patient. So the first step is to know that the patient is sick so that they can get some intervention. And then I think the really important part about the shock team is that you have all 4 members there. So as opposed to, for example, like how it could be now, like heart failure sees a patient. So KICU identifies a patient in shock. Heart failure comes to see the patient and they decide they need more support. They call the cath lab to see if the patient can be fit on to maybe get a balloon pump. They're also like calling the surgeon. Is it possible to get an Impella? Oh, we can't get an Impella for 2 days. Okay, we're going to go this way. So I think the really important, probably the most important thing about the shock team is that you have all 4 members there. They can all sort of evaluate the information that we have thus far. And I think you come to a decision faster about what type of mechanical support you're going to use for the patient. And so again, I think just like faster recognition of the problem and a faster recognition of what the solution needs to be. And so that these patients aren't waiting, days sometimes to get escalation of support.
Right. No, that's a great point. And I have other questions, but it looks like other people do as well. So I'll get to them. So if this is from Dr. Markley, thank you for that wonderful talk, Melissa. How can we better assess for ambulatory shock in the outpatient setting, especially in patients who are having a slow decline?
And I think those patients are challenging because frequently their symptoms haven't really changed yet, but you're seeing other characteristics that make them see high risk. And I think some of those high risk features that the navigator team is using to identify those heart failure patients that are at risk is sort of the same that we can do in clinic. So to me, 2 big signs of a patient at risk is someone that I'm having to escalate diuretics on, and someone that I'm having to remove GDMT because of hypotension or because of worsening renal function. So to me, those are 2 types of patients that are really high risk for having worsening heart failure. And then I think, again, you have to, I don't mean this in a dumb way, like you have to think about drawing the lab. So if you think someone is in worsening heart failure, you need to get the LFTs and the lactate to see how they're doing. Maybe this is someone that you want to do a right heart catheterization or a CPET on to see if this is someone that needs more advanced care. So I think for me, the 2 main things are the escalating diuretics and the withdrawal of GDMT, but then also with labs, if creatinine is slowly rising or there's other lab abnormalities. Those are patients that we would be happy to see in advanced heart failure if there was any concern about them.
Right, absolutely. Here's a comment from Dr. Lesniewski. Great presentation and discussion. I think objective assessment, the emphasis on lactate being greater than 2 is key. Sometimes it seems that clinicians underestimate because, quote, the patient looks good. And so that can be deceiving. And then a question from Dr. Abuzaki. Great talk, Melissa. Appreciate the overview and perspective. Would love to hear your opinion about the worst outcomes noted in the recent trial, the ECLS shock with ECMO and acute MI presented at the European Society of Cardiology.
So I do agree with the lactate. I find that maybe we're just numb to it, but sort of low level lactate people don't seem to think is a very big deal if the patient feels okay. I think with ECMO, by the time the patient needs ECMO, their outcomes are always horrible. So I don't know if people were that surprised by some of the outcomes. I don't know if I know enough about the study to comment more about that. I'm sorry.
Yeah, and Dr. Abuzaki, I can probably talk to you offline because I have thoughts about unloading and what I think Navin Kapoor is trying to do, and maybe that's sort of why that happened. Okay, all right. Well, I guess if there are no other questions, then I'll allow everybody to get on with the rest of their day. Thank you very much, Dr. Smallfield, for the lecture.
Thank you. Appreciate it.
All right, take care, everyone.